everybody. Welcome to week 4. We're going to have a lot of people in class tonight because Dr. Lundy's class joined in with us tonight. So I'm going to start the class with saying good work on your first exam. I think it gave us some guidelines on what we're going to work towards and make sure that we have, we're all ready to go for the exams going forward. If I sent you an email asking you to plan to go over the test, please do. I'd like to do that if I've asked you to go over the test with me. Any questions about the test at all? No? Okay. Tonight we're going to do week 3, a review of week 3, and we're going to do week 4. We're going to do some case studies tonight and some PowerPoints, some videos, some stuff like that. First, what I'm going to do is take attendance from both classes.
Professor,
yeah.
there are some people that are saying they can't get in.
Okay, I let everybody in the waiting room, so hopefully, thank you. Let me know if they still say they can't get in, because I have a bunch of us in here. Like I said, there's a ton of us in here. So, you know what? Actually, there's too many to take attendance. I'm just gonna call it, and Zoom will let us know who's here and who's not here. So that's good. Any questions at all for the good of the order for either class about what we have going on this week? For my class, I need your infectious disease by Sunday. Okay, so you guys pick your infectious disease as a group and send it to me and I'll approve it. And you guys can get working on that with week 7. Okay, you guys have an assignment week 7 as a group. Everybody should be up to date. Discussions were graded. Know that grades may be different among the group because your peer reviews were graded as well. So those were graded separately as the whole group. Any questions at all for everyone? Anyone for the good of the order? No. Okay, let's do.
I do have a question actually, Professor.
Go ahead.
So I just noticed that I have a 0 on the discussion, and when I go to the rubric, it says that it's because I'm missing the 2 peer response. But in fact, I did reply and I did on time.
Okay, I want you to meet with me privately, okay? Just stay on at the end of this.
Me too, Professor.
I'll send you an email because I can't stay like after class, so I'll send you an email. Is that okay?
Sure.
Okay.
Because I'll take a look at it. There was a couple on the discussion boards that I left a message for. So read in Canvas if there's a message with your discussion board. Okay. That might give you a clue as to what's going on. All right. So anyway, what I'm going to do is, you know what? Let me quickly take attendance. I'll do it as quick as I can. I'll do Dr. Lundy's class first. Ready? Dominique, just say here. Maria?
I'm here.
Thank you. Barbara?
Here.
Monica or Monica? Adria?
Here.
Valerie?
Here.
Eduardo?
Present.
Solange?
Here.
Keisha? Kelsey?
Here.
Felicia?
Here.
Mia?
Here.
Jessica?
Here.
Joshua?
Here, sorry.
No worries. Catherine?
Here.
Deidre? Peter?
Here.
Brittany Somerville? Delora? Sual?
Here.
Thank you. Rachel?
Here.
And Miguel?
Here.
Okay, guys, just a friendly reminder for both classes. Please make sure you guys are logged on right on time. I don't know what time I think Dr. Lundy has the same class as us. So just make sure you guys are all logged on at 4 o'clock because our new attendance policy, our new attendance policy is that a minute past 4, you're 15 minutes late. So just a friendly reminder for everybody.
Is it 4 or 5?
It's 6.
Well, it depends on where you live, so don't listen to me. 4 Mountain Standard Time, 5 Central Time, 6 Eastern Time.
Okay, thank you.
Okay, sure. I'm in Mountain Time, so a lot of times I speak in Mountain Time. So if I say something and you're confused, it's probably because I'm thinking my time. All right, Abby, I see you. Thank you. Devana,
Here.
Brittany.
Here.
Jocelyn. Isaac. You're here, Isaac. I saw you somewhere.
Here, I'm here.
Okay, thanks. Maloon.
Here.
Thank you. Blake.
Here.
Ashley.
Here.
Thank you. Sharissa. No, Sharissa. Courtney M. Courtney Martin. Sorry.
Here.
Courtney McDonald.
Here.
Okay. Miranda, I saw you. Judith.
Yeah.
Lucinda.
Here.
Thank you. Miranda.
Yes.
Shazay.
Here.
Taylor.
Here.
You're here. Brandon. You're here. I see you. Thank you. Marla.
Here.
Jamie.
Here.
Megan. Megan, you here?
Here.
Thank you. Becky.
Here.
You're somewhere. I saw you.
I'm here.
Okay. And for Rika.
Here.
Thank you. Alrighty, so that's our attendance for this week. And Zoom, we know we have to stay on camera. So
Sorry, Professor.
Catherine, I need
didn't
you.
hear my name.
Yeah, I called you. I called you Miranda
okay.
by accident. Sorry.
Oh, okay.
Catherine Leon Albert, I need your camera on or you cannot get credit for attendance. And Dominique, I need yours on or you can't get credit for attendance.
Sorry,
Just make sure.
Professor, I was trying to figure out my computer. I ended up jumping on my phone for some reason.
Oh, I see
something
you.
had happened. So I'm switching back to my computer. So I'm on there twice for right now. But
Okay.
sorry about that.
No, you're all good. And Catherine, thank you for joining on. Okay, so alrighty, so what we're gonna first talk about is the chapters from last week. Last week, everyone should have been on the it was really vulnerable populations last week. That's what we were looking at. So I'm going to show you a quick video on rural health just to begin the class. So I'm going to share my screen with you and just bear with me. I'll pull it up. I always share screens funny. So. Okay, let's share my noise.
Highlighted the power of agencies like the CDC and local health departments and brought backlash from people who said those authorities were overreaching. In the wake of this turmoil, many public health departments have been overhauled, having an outsized impact on rural parts of the country. With support from the Pulitzer Center and in collaboration with the Global Health Reporting Health Center, special correspondent Dr. Alok Patel has the story from Colorado. It's part of our ongoing series, Rural RX.
Emily Brown is busy with chores on the family farm, where they raise cattle and grow potatoes. It's a big change from her 6 years running the Rio Grande County Health Department.
My role as a local public health director previously had been pretty low on the radar, and then COVID came along.
COVID meant long days tracking cases, announcing business closures and travel restrictions.
COVID was hard.
And then, 2 months into the pandemic, the county commissioners fired her.
I think it was a culmination of just a lot of different tensions that sort of maybe came to a head.
Brown was the first, but not the last. Fully half the public health directors in Colorado have quit or been fired since March of 2020. A turnover rate that is alarming to Tista Ghosh, the state's former chief medical officer.
I would call it a nightmare for most of the public health community. So it's been a very difficult time and a lot of people have left.
The controversies did not end with COVID. Until late January, Kayla Marler was public health director in Fremont County. She says her downfall came after she tried to launch a family planning program.
When it comes to prevention, especially when it comes to birth control, It is something that is needed.
In these small mountain towns, options are few and far between.
And it was really disheartening as a public health director that I would have to tell my staff, you're going to have to let them know they're going to have to go to a neighboring county.
Marlar secured a federal grant to start a program that would offer birth control, test for sexually transmitted infections, and treat patients who needed help.
October of this last year, brought it to the Board of Health, and it was turned down.
So after they rejected your proposal, what happened then?
What pretty much happened is I was pushed out. I was pushed out of my position.
County commissioners say Marlar was...
I'm going to stop this for a second. I'm sorry, guys. This is not the video I wanted to show you, but I wanted to start with a rural health video, and I had several pulled up, so that was the wrong one. I apologize. So what I really wanted us to talk about was rural health. What did you guys find in your reading about rural health? That was our chapters from last week. That was our first chapter.
Prevention, making sure that the community is educating what to do before we learn about like primary, secondary, and tertiary.
Okay, can you give us a little more, Rachel?
Sorry.
You're okay.
I try to remember back to last week. Just for example, like for the diabetes, that was a big one. About like prevention, like eating right, exercising. It starts early intervention versus waiting till later on in life to do making the lifestyle changes. One of the things that they were talking about is like the medications and stuff to help with that. And so if you did get diagnosed with diabetes, and what else did I read?
All right, I think I want to focus this back. It's okay. I want to focus this back to rural healthcare. So rural healthcare is different than urban healthcare. So rural healthcare is more those counties and the lands where you have a lot of land, and there's certain things that go on in a rural community. What kind of things go on in a rural community?
The farming, agriculture.
Very good. What do we worry about with farming and agriculture?
Exposure to sun, no one knows. Exposure to
Can't hear you, Miranda.
pesticides,
Good.
hurting their
Pestis-
back.
Yeah, pesticides hurting their back. What else do we worry about? What kind of workers may be in our rural communities?
Migrant.
Very good, migrant workers. And so with migrant workers, we have a lot of things that go on as well. What kind of things do we look at with our migrant workers?
Like no insurance because it could be undocumented.
Good. Those in poverty. Good is another one. You're going to see poverty in rural areas. What else do we know about access to healthcare in a rural community that is different than a city?
Limited. You don't have all the options you have in
Okay, you may not have the options. Why are you not going to have the options?
there's, I mean, a limited space. In a city, there's more people, so you can have more doctors in a square mile radius than you can out in the country.
Okay.
Some of them are illegal and don't have insurance and are afraid to go and seek for help in medical system.
Yeah, you're going to see that with your migrant workers for sure. But as a rural community overall, what I want us to think about is how many of us live in a city? Just raise your hand. All right, so some of us live in a city. So this is going to be different for you because you probably have 6 or 8 hospitals that you can choose from when you're in a city. When you're in an urban area, what ends up happening, there's a big push right now to train physicians in rural healthcare because we can use something that has become very popular and it's called telehealth. So we can reach those people that can't get to the clinics. I don't know if anybody's seen any of the stories, but PBS News does a whole series on rural healthcare. And there's a woman on there who says she her husband was having a heart attack. She took him to the closest clinic, and then the closest hospital was 45 minutes away. So she had to put him in a car and drive 45 minutes with him having a heart attack. And we probably know the outcome of that, right? So think about those kind of things. We don't have that same kind of, Deidre, I need your camera on. We don't have those kind of things when we're in a city as much, right? So when we take a look at rural healthcare, I'm going to show you on a PowerPoint that I have that I will share with you guys. Oops, not that one. What you're going to see in rural areas is you're not going to be having that same opportunity that you have in cities. What else is true about rural healthcare as a whole? What is something you guys found that somebody mentioned poverty? And in the chat, somebody mentioned that they don't have the availability to get their resources. So like if you need a CAT scan, they may not have one close by, right? So you're going to travel far to get them. So just some things that we think about when we're taking a look at our rural communities. Migrant workers, we talked about a little bit, and that's important for us to know about as well. Any questions on rural health? Because that was your first, section, really. Okay, I'm going to share this with you guys as well. For some reason, my PowerPoint does not feel like working. Okay. We see a lot of poverty in our rural areas, and so that's going to be important. Who do you think is going to be at highest risk?
Ones that are uninsured, the ones that don't have they have low income, they're living like barely paycheck to paycheck.
Right, and we see poverty, our groups are going to be at highest at risk are going to be our kids
And our adults.
and our minorities and our single parent families, especially those headed by a woman. We're going to see that. So we know that that's a poverty concern. When we're looking at our rural healthcare, we think about the physical demands that we have on them. If you look at the pictures on my PowerPoint here, this is what they're doing all day long. They're bent over. We're going to be looking for injury to the back, musculoskeletal. We're also going to be thinking about rural clients are going to have less activities during leisure time. You're not going to have as many gyms. You're not going to have as many tennis courts. You're not going to have as much as that. We know that there's a decrease compliance with safety, and we have chronic disease is going to be more prevalent. One big thing with our rural communities as well is everybody kind of knows everybody because you're in a small community. So what ends up happening is we see a lot of decrease on reporting on sexual abuse, drug abuse, or depression. And the reason for that is people are worried that everybody's going to find out about them. If you're in a big city, a lot of times if you're living amongst many, many people, nobody even knows who their neighbor is. But in a rural community, everybody's going to kind of know about each other. We look at pesticides as a big one. So a primary strategy for us would be to provide education and teach workers how to reduce their exposures. We're going to do our hand washing stations and screenings, right, for our secondary. And so we know there's an overall decrease in health status when we look at that rural community because they just don't have the access, right? And they're less likely to participate in activities and safety precautions. So we see higher chronic disease among our rural communities. What ends up happening is it's higher among the rural communities, but they don't have the specialties out there. So they're not going to necessarily have endocrinologists that can get them in quickly or to be seen as that manner. Okay, so we just look at that as far as our rural communities. Any questions on that topic? All right, we are going to take a look at the next two were violence and drug, alcohol, and tobacco use. Does anybody know what the most commonly used drug in the United States that's approved?
Tobacco.
You guys both spoke at the same time.
Marijuana.
Well, marijuana is not legal everywhere.
Prescription drugs.
Alcohol.
Opioids.
We're getting a lot here. So opioids aren't legal if they're not prescribed, right?
Tobacco.
Well, you're getting closer. It's actually caffeine, according to our book. Now, I think all of us, I mean, I get heart palpitations now with caffeine, so I don't drink it as much, but in nursing school, I sure did. So I think that's just kind of one that we don't think about and we don't spend a lot of time focusing on that. Miguel, I need your camera on. But that is actually considered in our book, one of our drugs. I have a Kahoot. Would you guys want to do a Kahoot just to review last week?
Yes.
I don't know if Dr. Lundy shared it with you guys, but if she did, that's fine. We're going to review as we go through it. Okay, is everybody okay with that? Because we all teach differently, obviously, right? So let me pull up the Kahoot for you guys, and then we will do that together. It'll just give us an overview kind of what I expected you guys to have for your for last week's topics. Okay, so let me just get out of here and I'll pull up the Kahoot for us. So like I said, this is a review all of last week. This week we did parish nursing, home and hospice. And so we will get into that with our case studies a little further. But I just wanted to review because I don't want the content not to be covered relatively quickly. So everybody should have seen my lecture for this week. It is posted on our announcements, right? Everybody saw that. I know it's not as thorough as sometimes we would like. So we are always going to make sure that we go over the reading and all that good stuff. My computer is really acting up this evening, but maybe I'll get there eventually. Okay. Any questions about week 3 content? No? Okay, our Kahoot is going, does everyone know how to do a Kahoot? Yes, I'm hoping.
For the most part.
Yeah, I know Dr. Lundy is, I don't remember. Brittany, make sure your camera's on, please. I'm not sure she loves Kahoots. It's loading. So Kahoots, you just are gonna put in a PIN code and then we can all play. Sometimes it limits us to 10 people, but I want you to follow along even if so. Okay, here is our PIN. So you go to www, if you can do it on your phone too, there's the Kahoot app. Just type in the PIN 5612715. All right, so here we go, guys. All right, this talks about our Mexican immigrants because this is going to be a large migrant population. So which behavior would most likely lead to a positive interaction when we're dealing with our Mexican community? This was on our last exam, I believe. All right, most of it got it right. Very good. So, I'm sorry, someone's speaking. I can't hear them.
Oh, I'm sorry. I can't see the question. It just came up with squares.
Is anyone else having trouble with the questions?
Yeah,
It
you
should
just
be-
have to look at the Zoom to look at the questions.
Yeah, the questions are on my Zoom. All right, so avoid touching the client except when necessary. And our Mexican immigrants, we don't see that, okay? They don't mind physical touch as much. They really want to socialize. They really see nurses as a very powerful community, and so things like that. So you're always gonna want to be respectful. You're gonna talk to them, tell them a little bit about yourself, that kind of thing, call them by name. So very good, most of us got that one. This one we're gonna skip, so don't worry about this one. RN is implementing a tertiary prevention strategy related to pesticide exposure. Remember our tertiary, secondary, primary. Beautiful. You guys are good on your tertiary. Remember, our tertiary is going to be meaning we're going to look for this word that is here. And so when we're doing tertiary prevention, remember, we're doing a treatment for a client that already has a condition to minimize our complications. So good. It was going to be treating one who has it. Okay. Observing farm workers for evidence of unsafe handling and pesticides. What level would that be?
Secondary?
Yeah. Why is it secondary? You guys are both right.
Like a screening?
Yeah, we're screening. We're looking to see what's going on. We're screening for evidence. Good. All right, let's see our next one. Which of the following has our highest risk of poverty? Now, this is one that we didn't really go over, but think about highest incidence of poverty. Okay, so we said those over 65. So remember when we were talking about where we see in our rural communities, we see it among kids is one of our vulnerable groups. I would agree with you though. I like those under 18 and those over 65, because once you're over 65, there's a fixed income that takes into effect. This question wasn't clear enough. So I was looking for it more in the rural communities. Okay, so those of you that picked those over 65, that might be among the general public, but in our rural communities, we're going to see those kids are really high risk of poverty. The most rapidly growing group of homelessness. This was in our chapter in our reading on homelessness. Oh, good. We were split there. People in crisis and families with children. So our largest growing group of homelessness, unfortunately, is going to be our families with kids. Persons in crisis. I'm guessing we answered that as much as we did thinking of our vulnerable populations, but that's not going to be a rapidly growing one. They're already part of our homeless community as such. A nurse is assessing a young single pregnant woman. Which of the following would be of most concern? Well, we were all over the board here. Somebody who picked first prenatal visit at 5 months gestation. Can you explain why you picked it? What was your thinking?
I picked that because she pregnant and she hasn't had any prenatal visits, so that could put her at risk for at risk to be sick.
Okay, at 5 months, oftentimes the way I want you to think of this is priorities here. So when we do priorities, somebody who picks homelessness, tell me why that's a priority.
They don't have shelter. They don't have a guaranteed food and all that stuff, resources comes along with.
Maslow's appointments either.
Risk of other disease processes,
Like
and exposure to cold.
Lack of nutrition.
concerns, and tuberculosis.
Yep, you guys are all saying the correct answers. So when you're in the homeless community, there's so much vulnerability there to lots of different things. What do we know about our young pregnant women? What do we really want to push for them?
making sure they get care in their first trimester and getting the most education out of their care, because sometimes they don't go to every single visit. So if you get the foundation of like the importance of every visit, you know, to decrease the disease processes, or, you know, make sure they get the right nutrition, make sure, you know, the baby's developing, make sure they start prenatal
Okay,
vitamins.
so this, I'm just gonna stop you for 1 second. So this answer is very specific to our social determinants of health, which we talked about in the first week. What do we know occurs when there's a low education? What is there an increased rate of? Starts with a P.
Poverty.
Yepers. It's a direct correlation. So if you are going to have a young pregnant woman who is not getting educated, then we are kind of setting her up for likelihood of poverty. So we want to be very careful about education and poverty. I know you guys are taking OB or have taken OB, and yes, prenatal care is very important. But if they don't have a place to go, there's no way they're going to get to appointments. There's no one who can drive them. They certainly aren't taking vitamins if they're homeless. So this is going to be a lot of things that would make them the most concern. Okay, good thinking on those, though. I like how you guys thought it out. We'll skip this one. You guys are postpartum out probably from OB. What is the leading cause of disability for Americans 15 to 44? This was in our chapter about vulnerability and vulnerable populations. Okay, who's at most risk for accidents? This goes back to week 2. Who's at most risk for accidents?
Adolescents, they're starting to drive, get their license.
And kids, school-age kids, they fall all the time, right? Arthritis, you're not going to see at 15 and 44, hopefully. And so what we know, living and workplace injuries is not going to be our priority at this age group. Everyone is aware of the mental health crisis that's going on post-COVID and even before COVID. That's going on particularly among this community. It's harder to live. The economy is in needs a lot of help. We have a lot of things going on during this age period that we have to think about. We know 15-year-olds, 16, 17 are adolescents. Depression is going to be a big thing that we are seeing. We'll skip this one because I have a feeling we'll skip that one. We're trying to decrease the risk for depression among older adults. What might we do as the nurse? All right. Why is this? This was very good. This is a primary intervention. But why did you guys, somebody who picked it? Tell us why you picked it.
For socializing, basically.
Okay. And what else do we know about healthy activities?
Keep them moving and keep their bones moving.
It could.
Alive longer.
Decreases depression.
Yeah, healthy activities and activity will overall, if anyone's done any work with exercise, we know that we get things that are produced in our body that create positive thoughts as opposed to our risk of depression. They're going to be around other people. It's going to be at a local senior center. So things like that. That's going to be our best intervention there. All right, drug addiction was on one of our chapters last week as well. So there's a whole suggestion on it. There's an approach that we do that's the most effective way to work with drug addiction. Wow, really? You guys, why did you guys pick education? Because this was a big section in our reading. So I just want to see what did you guys think when you said that? Were you just guessing, or was there something in the book that drove you that way? Because our harm reduction, we're going to see that all the way through drug addiction. Because the less we see someone around that, the less they're going to be likely to use it. So tell me about substance abuse education, somebody who picked it.
I chose it because if you're educating them about it and they're understanding the process of it, it might help them steer away from it.
Yeah, but you know what's unfortunate? If you look at substance abuse education, we do it across the board from kindergarten through 12th grade. It really doesn't do a whole lot. Kids are aware of it, but if kids are interested in doing it, they're going to do it regardless what an adult stands up there and says, right? So we want to think about our harm reduction. We're going to do our risk appraisals. That's how we're going to be monitoring and approaching our drug addiction. Just when I told you guys, this is caffeine. What is the following an accurate concern about marijuana? Good. However, I like that most of us picked that. Remember, our accurate concern, what we know for a fact, is that marijuana does damage the respiratory tract. We'll skip this one, but just pay attention to the drugs that were talked about in this chapter, and why that's important. All right, stopping a client from smoking, which is the best for the nurse to suggest? Okay, why would nicotine replacement products not be our best method for someone to stop smoking?
You're still giving them nicotine.
Yeah, you're still giving them the drug, right? You're just saying do it in a different way. We know that nicotine is very addictive. So if you continually give it, they're just going to crave it as you would any drug. So you're going to do environmental changes. You're going to do a lot there. School nurses, drug screening before problems develop. Okay, everybody across the board. So what word that tells you secondary?
Screening.
You see that word screening? It's our secondary, okay? A primary prevention would be educating, like substance abuse education, although that's not particularly effective. That would be a primary intervention. Here's an example. Let's skip that one. This has to do with our smoking. Mainstream smoke and side stream smoke are examples of. Oh, good. Almost everybody got that. It's secondhand smoke. I don't know what addictive smoke is. Okay, migrant farm worker presents with abdominal pain, nausea, vomiting, diarrhea, and a headache. What is the cause? Wonderful. When we see migrant worker, the first thought we should think is pesticides. We're worried about them. They spray them all the time. They're in the fields. They're sprayed over everything. They're taking that in. So very good on that one. We're always going to think of migrant workers with our pesticides. Many barriers faced by those who live in rural areas. What's one more they may encounter? Excellent. That's our primary barrier that we see, because if you have an emergency and you're in a rural area, we're having a really hard time getting people where they need to be quick enough. If the hospital is that far away, it's pretty hard to get them to where they need to be. Culturally competent care, you're going to see that across the board. That's just not in rural communities. What you're going to see is you're going to see that everywhere. High cost of healthcare is everywhere, and availability of specialists is one, but our primary one with our rural is going to be our distance from our healthcare facilities. Any questions on those, that Kahoot? No, we're all good on that. All right, we're going to take a look at home and hospice nursing real quickly, and then I'm going to have you guys do some case studies. So for my class, I usually let them out 10 minutes early as opposed to taking a 10-minute break. Can I just see by raising of hands who wants a 10-minute break? Okay, so majority rules, so we'll end 10 minutes early for you guys. You guys have a test tonight too, don't you? Peds? Yeah, so I know your brains are everywhere but here in community. So I will try to be sensitive to that, okay? All right, we're going to take a look at hospice and healthcare. I have a little PowerPoint that is a little, here it is, that I altered a little bit from the book. My class, I will be sending out to you the PowerPoints for this week's reading. I always forget that, I don't know why. But I'll send that out when we end class tonight. All right, so home is a place, when we talk about home health care, home is a place where nurses have provided care for a long time. Clients who are homebound, home care is sometimes a necessity. We look at taking care of family because when we're in the home, our priority is looking at the family as well as any caregiver or significant person who assists the client in the home. When we're working in our home, we're going to practice autonomously. Therefore, we have to be careful. Home environments may lack many resources that we find in our institutions. And working in a client's home, make sure to remember you're the guest and you want to have effective communication with them. Some practice methods that we look at is population-focused home care. So it's directed toward the needs of those that have specific illnesses, like our cardiovascular disease or diabetes, and our families with infants and young kids. We have a different transitional care in the home where it's designed for those who have complex or high health problems, and we're going to make a transition from one level to another. We also have our home-based primary care, where our emphasis there is going to primary care in the homes for people who can't come to the primary care clinic or physician's office due to health problems. We saw this a lot with COVID. Doctors' offices would not allow people in the office if they had COVID, so they would just keep them home and say, stay at home and take care of yourself. This is what I want you to do. When we take a look at real quickly our scope and standards, direct care is our actual physical needs. So we do physical assessments, we change dressings, we give meds, use our catheters, all kinds of stuff like that. We take a quick look as well. There's quality management that is accountable for in our home health nursing. So please be aware that although no one's in there in the home with you, you're going to make sure that you're following all standards as if you were in a hospital setting or institution. Lots of legal and financial stuff that we think about. Medicaid, Medicare, there is one that will reimburse for only nursing service in the home. And does anyone remember what that one is?
Medicare.
Very good. Medicare is the one that will cover nursing care in the home. They will not cover someone to go into the home and babysit or keep company with the person who's in the home, okay? And then we look at our trends, our Healthy People 2030, family responsibilities, and we know about our telehealth is helpful in the home setting, as well as our HIPAA. Any questions? I know it's quick, but any questions on in the home? All right, we have 5 case studies that we're going to work on tonight. I'm going to split my class up. Split all the classes together. We're all doing it together. We're going to do a Jamboard as usual for our answers. I know last time we cut it short, we missed 2. So my expectation with these case studies is everyone participates. My class will be getting a copy of the case studies. Dr. Lundy's class is going to be in groups with my class, so they will be sharing. Does everybody understand what we're doing? You will get a case study. You're going to do some questions on it. I will emphasize to you, the purpose of this is to pull your reading and the knowledge that you've learned over week 3 and 4 into a case study. So I don't want you to focus on things that might make sense. I had a meeting with a student about the test, and she said it was a little difficult because she thought it was just like, like kind of common sense. And what I told her, and I will tell everyone, is that what happens with community health is people are like, oh, I know, like this is kind of easy, but it's very specific, and your reading gives you specific objectives that you want to learn, okay? So just keep that in mind when you're answering these questions. It's really helpful for you to answer them and for learning purposes, okay? Any questions? Let me share the Google Doc with you guys right now. The Jamboard. If you don't know how to use a Jamboard, my class does, so just ask them, they can do it. And I will randomly split you guys up into groups, which is the way we normally do it.
Are you going to give us a link to Jamboard again?
Yep. I'm just getting the link for you now. Okay, so there are 5 case studies. Depending on what case study you have is what slide you're going to fill out with your questions and your... I want you to be thinking AdPi with our case studies, but there are specific questions that will help guide you with these case studies, okay? That has to do with the content that we should have found in our learning this week. All right, here we go. Here's our link. It will, hey, where'd you guys go? Okay, it'll be in our chat. So what you have to do is you click on it. Don't worry if you can't get it. Sometimes people have trouble, but you're going to be working in groups, so somebody in your group will be able to get to your Jamboard. Okay, what we will do is we'll meet as a group, and then we'll come back together as a whole, and we'll share the case study and some findings that we had with the case studies, okay? So everybody should be hopping onto the Jamboard. It's in our chat there. My class is getting your email right now.
I don't have it in the
See it in
chat.
the chat. Jinx.
You should see it in the chat. Everybody see it in the chat?
No.
Nobody sees it in the chat.
Nobody sees it in the chat. Oh, it's because I only shared it
Yeah,
with one
it's not
person. That's why. I shared it with one person. Courtney, you got it. Okay, there, everybody should have it now. Everybody in my class should be seeing our case studies.
So we log into that link individually and you're gonna put us in groups?
Yep. And my class will get the copy of the case studies and they'll share it with the groups because I don't have everyone else's email.
Professor, doctor.
Yes.
Sorry to bother. I was in the bathroom and I came back. We're supposed to go in the groups and I'm supposed to log in the...
On the Jamboard that's in the chat.
Okay. Thank you.
Mm-hmm. Okay. It's coming your way. And like I said, these are really good for everyone, because they will re-emphasize our reading through the week and I'll help guide you guys. Okay. So I'm gonna break you guys up into groups. We'll do 5. Elisa, I just need your camera on. I don't know if it just came in. It's saying there are too many people viewing this file. Okay, so let's do it this way. I've never had that problem with the Jamboard, but my class accessed the Jamboard. Dr. Lundy's class, you're just going to be contributing. Okay.
My camera been on this whole time.
Okay, well, your camera was just black, so. Alrighty. So we're doing 5, depending on who you are. They'll go randomly. Okey doke, here we go. Dominique, are you joining? Your breakout room. Okay, are you guys all done? Because you're just sitting here.
Yeah, we got kicked out and then we never were put back. Our Wi-Fi.
Okay, so it'll come up on Zoom. Nobody was kicked out, like, you know what I mean? So it'll come up on Zoom when you guys joined. You guys look like you joined late in the whole game, so it'll come up on Zoom though, so.
No, we joined class at 6, but we got kicked out of our breakout rooms because our Wi-Fi went out. So now that we came
well,
back in,
yeah, we can't really worry about that, so we'll just get all back together and then, you guys missed this section, but you know, there's nothing we can do if you get kicked out of Wi-Fi and we're on breakout room. So hopefully you'll get some content from when we come back together, okay?
okay. I mean, we can see the Jamboard, what they're putting in, so we can read the information.
Yeah, so that's good. Yeah, that's good. Valerie, why is your camera off? Make sure you put it on, okay? Rooms. All right, we're all coming back, so let's just make sure everybody comes back together. All right, so you guys had 5 different case studies, all different sort of topics, just a little bit. I'm going to help guide you guys as much as I want for what your finding was. I joined everybody and you guys were working really well together, so I was happy about that. I'm going to ask one of my, oh, I can't double share. All right, let's take a look at case study number 5, please. Group number 5, we're going to look at our Google Jam here. I have my book open, but here. All right, here is our lovely Jamboard, and I hope we have 20 slides.
We're on 6. Yeah, this is us right here.
6. Okay, so tell us a little bit about your case study. What was going on?
So we had a 29-year-old who was diagnosed with bipolar disorder, and he also has alcohol addiction and marijuana.
Okay. Yep.
And
he's
so,
go ahead.
Yeah. Sorry, and he's admitted in the in a mental health hospital.
Good. And we looked at, our first thing we looked at is what's our relationship between addiction and mental illness?
Yeah, here's our board. We said that it addiction and mental health. I'm not the person to
I got it.
use.
It's cool. It affects his coping mechanism.
Okay, that's one relationship. What do we see? And I'm going to stop sharing here for 1 second to show you in our book what we see about our relationship with mental illness and addiction. Oopsie. And we took a look at this. We saw this in our reading. And I'm going to share with you guys in 1 second. And we looked at that relationship. And we saw this relationship, and we know that this is true. And in our chapter, we were looking at chapter 26, which was our reading. And then when we go down, we take a look at our relationship here between, and we see that when we are diagnosed with a SUD, which is going to be a substance a substance disorder, then we have these different things that we're able to do. So we know that they take those substances in larger amounts. We know that we wish to help them decrease it. We're seeing they're not able to perform at work, home, or school. What did we find in our case study with this guy? What was his concern?
He was divorced and he's a construction worker and he was afraid to lose his job.
Yeah, so here we see this has been impacting his, not only his work, but his home. And then maybe he's giving up some activities, using substances that put him in danger. What did he do that he did that put him in danger here in your case study? Remember, he had $100,000 in property damages because he was under the influence. So we saw that in our case study. And so that was important stuff that we looked at there. Okay, let's go back to our Google Jam. And on that, what did we see was some of the concerns, or what are some assessments we're going to do when we're with our, hold on, I have to stop sharing and share with you again. This is so silly. What did we see with some of our assessments that we're going to be doing with him?
The risk assessments.
Good. We talked about risk assessments. Tell us a little bit more about those risk assessments.
Maybe suicidal thoughts or.
What were we looking at there? When we're looking at our risk appraisals, what are we looking at? Somebody other than this group can always help. What are we looking at when we're looking at our risk assessments?
Probably like who he has access to, who he hangs out with.
Where is he getting? Good. Where is he getting whatever he's getting? Do all his friends take drugs? Do his family, is his family taking drugs? Is he taking substances because he thinks it's going to help with his mental illness, right? These are all risk assessments that we're going to be looking at with anybody with addiction. Very good. And then our role, what's our, well, we also want to look at one other thing that you guys have up here that I want to just speak on real quickly.
Oh,
another assessment.
The therapeutic communication and safety, getting the patient through rehab.
Yes, and we said getting into rehab is going to be our tertiary prevention. Very good. With our case here, he was an addict already. So we don't have a lot of primary prevention we're going to do with him regarding his addiction. But we can do some primary and secondary with other things, right? Not with his addiction, not with his mental illness, but different behaviors or different things that he's going about that is not a condition already. We know that we look at the genetic connection with any addiction. Please keep that in mind. There is a genetic connection between addictions and families. So when we look at our risk assessment, we're going to look at what did that family have? What other kind of things did the family have so that we can help with that? Okay. All right. Good work, guys. Page group number 1. Tell us about your case study.
Man, how'd they get so much room?
They made their boxes smaller.
Huh. I didn't know that I wasn't.
It's okay. Group 1. Anybody there?
Yes.
Okay.
I guess.
Go and tell us what you guys had.
Where is that? We had the question 1. Let me go back to it. So we had the case study with the Delta County. It has you want me to read the whole case study or just sum it up?
No, you summarize it.
Oh, okay, yeah. We had the Delta, basically the family live in a rural area, a population of about 15,000 people. The hospital, the nearest hospital, the closest one is 60 miles away. Only 2 nurses in this community. For the health department, there's a primary maternal infant. So like one infant, like I guess neonatal nurse or that type of thing for like child well visits. So just one primary care physician for the well child visits. The family have, I believe, 3 three children.
Yep.
She has type 2 diabetes. She's diabetic. She has a husband as well. A lot of where she lived, the two primary care dentists and the doctor, they don't take Medicare or Medicaid. And she can't really afford her type 2 diabetic medications.
Good. So we first looked at, is this a rural or a urban community?
This is a rural community.
Right. So we have 15,000 people in this community, approximately 12 people per square mile, which is going to be our rural communities, anything fewer than 20,000. Okay. What barriers did we see here?
The most important one, I feel like the hospital being so many miles away, that's kind of scary. I felt like that was a barrier.
Good. Another one that you guys looked at, let's see.
The financial barriers that they have.
Yep. Lack of financial.
The
They
ability
also
to
have
get their meds.
Yeah, they can't get their meds. They can't afford the meds, right?
They can't afford their meds, yeah.
Okay. And so we looked at we know that our healthcare providers are not really going to be overly helpful because they are for primarily maternal infant health.
Right.
That doesn't really help us much, right? And that's what they have. So we're going to see outreach services are going to be limited because we don't have those doctors there. Some solutions though I like that I see here. We have case management to specialize with their care. Big thing in rural health is going to be telehealth. Excellent. Telehealth is going to be us getting on the phone and talking to them via Zoom or whatever they want to use. Okay. Dentists not accepting Medicare and Medicaid is a problem in a rural area. We're not going to have those private insurances, right? So something else to think about. Good. We talked about, these are some resources, you guys. Doctors on the go is a big thing. There's a lot of med schools that are training doctors specifically for rural care. So I like the way you guys came up with this. Case management here is going to be key. Okay, we're going to need to really coordinate everybody all together, help them get the services they need. We got to get her meds. We got to work with the lack of insurance, those kind of things. So we're going to do a lot of coordination of care here as the case manager. Excellent, group number one. All right, group number two, you're up. Tell us a little bit.
Do you want me to like give a summary of the
summary? Yep.
Okay. Basically there is I don't know where I went.
You're fine.
Basically there is a community mental health service agency. It seeks to prevent basically I don't know.
Yeah, it's a mental health facility.
Okay.
Okay. And what the role here is that we're doing an in-service for all new nurses. That's our scenario going on here. So how can the nurse act as an educator? How are we going to educate among this vulnerable population?
So we had a few different things. We discussed maybe going to schools to discuss with children the early signs and symptoms, putting out flyers around the town for the people to see, teaching clients about their families with their being like self-care strategies, but also like healthy lifestyle choices, stress management techniques, and coping skills. There is medication that can be given as well.
Yeah, good. What kind of factors of mental health influence our community services? What do we need to do as community nurses related to mental health? Anybody can help here.
Yeah, because that's not where we went with it, I guess.
Making sure that they have like someone they could talk to, like social work, case management.
Different groups as well, giving them resources to different peer groups.
Good. We have peer groups, we have support groups. Good.
Medication management.
Yeah, we can help with medication management.
Polypharmacy.
Mental health illness. Yeah. mental health illness is a problem across the board right now. So anything we can do to help promote those healthy behaviors, like we did in the ARCA with those, you know, at a senior center, doing something active, getting kids active to try to help with this, you know, mental health concerns. We see mental illness needing a lot of care coordination as well. So all of these vulnerable populations need some help with the care that they're getting, okay? We want to emphasize that. We want to advocate for health insurance to cover our mental illness care, right? We want to supervise our diagnostic tests and make sure our care is getting documented well. Okay, good. We have 3 and 4 to go, but we're at 5:32. So I went over home health with you guys, and then just really briefly 4. Oh, 3 had those nice pictures. Wait, 3, you got to do 3. Just do it quickly. 3 was let's see.
It was the shelter, the Hearts in the Hand shelter. It's a halfway house that for abused women who have left their husbands.
Great.
The shelter provides individual care in groups, basically trying to get it back on their feet.
Yeah.
They must, and if they're gonna stay there, they have to help with like chores like cooking and cleaning, taking care of the kids, for childcare. And then you want me to go on with the questions?
Let's just tell me a little bit about what you guys found in this case study. You're going to do something therapeutic. What are you going to be doing? You're going to be making sure your environment is what?
It's comfortable and non-threatening environment.
Good. And then we look at ensuring health practices are culturally competent. We're going to be sensitive to the fact that individuals that they're assessing may have different priorities than their own. This is where we look at nurse bias. Very good. And then Nurse Robin can empower clients by ensuring health promoting strategies. We just talked about that a little bit. Advocating for our clients, understanding women are at a shelter for a short time. So let's make sure we get them all the services they need. Excellent. Where would we go to some steps that home health nurses do for effective care in the home? Health departments, American Red Cross, food and clothing banks, our missions, our shelters, our social services, Salvation Army, all of those are going to be some resources we can do in the home health care. Very good work. You guys worked hard tonight. Group number 4, we're going to meet the beginning of next class. You're going to go over your case study beginning of next class. For the rest of you, best of luck on your peds. I will post PowerPoints to my class. And if you guys have any questions, I will you can ask Dr. Lundy, she can clarify for you. Group number 4 will come back together. Thank you for joining us, class, and I will be ending now. Best of luck on our exams.
Can you
this
say,
week.
thank
I need
you?
to speak with you. Yeah, no worries. I stay on.
Thank you.
Okay.
Thank you.
Thank
All
you.
right, thank you. I just have to
Yeah, I
mute.
see she's still on.
Yeah, there's a bunch of people still on. So I'm just going to mute for 1 second and stop my video just for a second. I'll be right back. Alrighty, sorry, I'm back. Okay, so I see several people here, so I'm gonna pull everybody into a breakout room and then we'll work it out together, okay? Because one person, oh, somebody just popped up. So one person I had asked to meet after class. So that one person, you know who you are, but I'm gonna put everybody else in a breakout room individually so we can discuss whatever you guys want, okay? So hold on here.